This is the Midwifery Scope of Practice Advisory Committee, and today's meeting will be from 4 to 6. We have the agenda. We've got a call to order and welcome and introductions. Then we'll need to review and approve the April 15th meeting minutes. We'll have the discussion of the current changes to the most recent draft midwifery rules. And then we'll have a chance to discuss the recommendations from the advisory committee. So we're going to do some small group breakouts by profession or group that you represent here. We'll do a presentation of what you discussed during the breakout, and then we'll discuss that information and then have closing remarks.
So Will, do you want to go ahead?
Thanks for investing more time in this, everybody. I'll call the meeting to order. It's about 4:01, and we have a quorum, so we can go ahead and get started. Everybody has the agenda in front of them, and we've opened the meeting. So does everybody want to just introduce yourself real quick for the folks that here that might not know everybody, and then we'll press ahead with the minutes. So I'm Will Humble, the director for the department.
Allison Bernstein, a member of the public.
Maria Manricus, I'm on ACOG, Arizona Section Chair.
Jeff Rosen. Former Summit Healthcare, also represent the Arizona Association.
Chels Bobby, certified nurse midwife, Gilbert, Arizona. Mary Langlois, licensed midwife. Wendy Clarkner, licensed midwife and president of the Arizona Association.
Okay, so let's go ahead and move to agenda item B, which is review of the minutes from our meeting on April 7th. So that went out as an email, but I don't see hard copies here for everybody.
We did not print hard copies out of the minutes.
Okay, we don't have hard copies of the minutes. So does anybody on the committee need the hard copy of the minutes?
I can
Everyone
pull
has a
them
chance to
up
look at them?
online.
Okay, we can go ahead and have a motion though if everybody's comfortable.
Well, I just like it added to the minutes that it was noted that there was a violation of open forum meeting rules and it was public review. So if you can include that in the minutes, that would be appreciated.
Oh, so you can make a motion to approve the minutes subject to changes.
I motion to approve the minutes subject to adding that it was noted that open meeting rules were violated
So we have a
during
second?
last meeting. During the meeting.
Well, that would be on we'll do that in discussion after we have a second.
Okay.
Okay, we have a second. Any discussion? Now we can talk about it.
During the meeting, you and Wendy communicated that you had worked with the midwives and gone through the draft guidelines and requirements with other midwives, which is a violation of open meetings.
How is that a violation?
We had a second meeting that went through all the rules,
Right.
and that was clearly stated that we can communicate together as a group, but we could not meet, for instance, Dr. Northrup and myself with colleagues.
Then it had to be a quorum.
No.
My understanding with Dr. Linda Valdez, it had to be a quorum in meeting.
No.
Because after that meeting, I contacted her directly after the December meeting and asked her if I could communicate with the midwife.
You personally can't. You one-on-one, not one or two, not 1+ members. So I can communicate with my constituency, but I can't meet with Dr. Northrup and meet with my constituency. And that was well communicated to us in our second meeting.
I went back and read the open meeting rule law after that was, somebody brought that up after the last meeting, and it said a quorum. A quorum is more than 4, is that correct? There's 8 committee members.
So I'll add a little bit to
Okay,
this section
okay.
here. So for us, in order for us to move past this agenda item, how about we include in the minutes the follow-up email that Kara, that you sent, that Tom Salo sent to everybody on the committee, clarifying what the requirements are for the open meeting line, include that email in the minutes.
As
and
long as
with
we
a line-
acknowledge that the reason that was sent out is because after the meeting, we brought that to your attention, and I believe other members from the meeting that were present brought that to your attention as well. So fine, that's fine, but let's be transparent in why that second email was sent out.
Yes, so we can notate there was an allegation of a violation and provide that email that was sent out because of the violation of the relation of meeting.
That would be.
And then any documentation, it's a good thing we're filming everything on live stream,
Yeah.
which the camera's back there again this week. So any question about whether we have it, collected for posterity on our website so anybody can review that. So with that noted, could we have an amendment to the motion that to include the email that Tom Salo had sent out in follow-up for that meeting, and attach that to the minutes,
I'm just
noting that there was an
requesting-
allegation of the
Correct.
of violation of the open meeting law.
Correct.
So do we have a second?
Second.
Okay, so that was not my motion. I
That was
just
my
said what your motion was.
That was-
Are you okay with what I just said?
I'll claim ownership of
Okay,
that motion.
and we have a second from Janice. Any further discussion? Okay, all those in favor, please say aye. Any opposed? And anybody not voting? Let's move on to agenda item C. So Tom Salo is going to go through the discussion of the rules as they stand, and we sent out the link to the most recent version of the rules. And what we've got up on the screen right now are mainly the changes from the April 7th meeting to today. So you'll see the differences between the two.
Is there a way for it to be in front of us as well? It was like.
Oh.
Yeah, you can, since we weren't able to get that screen up this time, you can roll around and sit on the other side or tweak your head. Okay, so Tom, you have a mic.
I do. Can you hear me? You can't talk. Okay, as we'll describe, I'm going to describe the most recent changes to the previous draft. If any of you have questions during this, please ask away, talking to the committee. There's only a handful of slides, and I'll try to be as thorough as possible. Please ask any questions you may have. One of the changes that we made was the reporting requirements. We struck out the client's name, and part of the reporting was to provide us with the client's number. So if we have questions as far as a complaint, whatever, we can ask you for the client's number, which then you can match with the file and provide us the whole client file with whatever we need as far as the investigation. Must be clarified that a notification to the department of a newborn death within the first 6 weeks. That was consistent with the reporting requirements for the postpartum period to report your current quarterly report. To try to provide clarification for all of that, 6 weeks across the board.
So that's a fetal death that happened within the first 6 weeks, but the reporting requirement is within some number of days, right?
The report of the death was within 5. The quarterly report is 6 weeks.
So the report of the death needs to be within 5 days of a death that happens within the first 6 weeks. And then is that notification in write? Is that electronic? What's the method of notification?
We're going to add, at least for the 5 day, the death, notifies within 5 days of death. We're going to ensure that that's done electronically to the department. And this one, I believe it says in writing right now. We can put it as a department credit format as well.
Yeah, I would rather have that as to make a modification to make that electronic.
We're trying to get all of our reporting electronic across the board for all the midwives. Any comments on this slide?
But go over the third bullet.
Oh, the administrative rules. Overall, you'll see some exceptions later on, but the whole package will likely go into effect on July 1st of this year.
But there's exceptions in that the expanded scope for VBACs would be July 1st of 2014.
VBAC and breach. VBAC and breach.
So VBAC and breach would be, so like we talked about the earlier meeting, that would be a July 1st of 2014 implementation date to give time for the training.
To give time for the training.
Where is that noted in the document?
It'll be in the next slide or two, and it's also on the bottom of page Rule 108 or 109. It's on, bottom of page 17, right above 109, subsection N. It says subsection B and J3 are effective July 1st, 2014.
Thank you.
So far, so
We're
good?
gonna do that on another slide.
The breach and the VBAC? Yes. We haven't talked much about it since one of our earlier meetings, but a lot of the processes, the applications, renewals, the continuing ed, timeframes, name change, duplicate license, that stuff has been pretty much the same since it was the second or third meeting. We haven't had much feedback during the comment period on it. Obviously, most of the comments have been around the scope of practice. Have you guys thought of any comments on or anything about the application requirements since the, there's a smile.
The only thing I can tell
I'm just gonna run this.
The only thing I can say is the goal of this was to reduce regulatory burden, and if you're asking for us all to be CPMs, to require continuing education or show evidence of our neonatal resuscitation certificate, any of those things are already required by the CPM, so to require them to be presented to the state again is just increasing your burden. So if you're going to ask us CPM, I don't think you need to ask us for continuing ed or any of those things, because it's all encompassing in the CPM. That's
For the CPR, I know we addressed it after that second meeting. If you have a CPM, you don't need to provide us documentation of CPR.
And I would beg that the department has demonstrated up to this point a not very good job of collecting data. So I think it's relevant to, at least in the initial period, to include those things so that you understand that you have, it's not that hard. And I have to do it, my basic life support, my NOWs, I have to present that to my department, to my hospital, to my credentialing. I realize it seems like redundant work, but I think it's important for the Department of Health to be able to demonstrate that they collect that data, individual, and not just take for granted because someone is certified by another governing body that you have in total the information.
And to answer your question, back to on page 7, it's A2. It's either documentation of the NARM, or if you're a midwife licensed after 99, provide the CPR. We can clarify that too if it's not as clear. Any other comments on this slide?
Only one thing, before we move on from administration was we had talked, I brought it up a couple meetings ago about the students right now. We had talked about that. Is there going to be anything, they're just gonna have to do the NARM then? Is that what we're pretty much moving forward as of July 1? And you just get all their paperwork as far as for the CPM and?
Correct.
Oh.
Okay, the responsibilities of a midwife. Let's go to practice. specifically Rule 108, which starts on page 11. We expanded the scope of practice to allow for C-sections under certain circumstances. Or VBAC, excuse me, I think that's like the third time I said this meeting. And allow a fetus in a breech presentation. We removed multiple gestation, and in order to do the expanded scope of practice in that first bullet point, must be NARM certified to manage those higher risk pregnancies. And as we discussed a few minutes ago, this will go into effect July 1st of 2014.
So, and I'll hand these out if you don't mind.
You haven't defined breach well enough for the home setting. You haven't defined breach at all. So I think it's relevant and important to define breach. And I would ask that you include complete breach. And yes, I recognize that breach was in the initial, but it wasn't well defined then. And then the Department of Health, and thank goodness for our midwives and everybody else listening, they recognized that there was a national trend away from breech delivery. And that's all in question currently, and I understand that. But again, these rules were populated in 1994. The current trend was changed in 2001 to not trial planned breaches. So two things are happening here, which I don't think many of us recognize. One, it was already in here to deliver breach, but that was an error, in my opinion, on the department to not recognize the trends of change. So when practitioners in the hospital were not delivering breaches by vaginal method, it was possible for a home delivery to occur, which, I mean, I personally think that was a great error. Secondly, you're not defining breach, and not all breaches are the same, and that needs to be better defined.
Thank you.
She is correct in the sense when you look at definitions, it's not in it. It's not in it.
In the rule part on page 19, it does say that you can't do, a midwife can't do one for somebody in an incomplete breech baby in an incomplete breech position. But I agree, it should be in the definitions, but it is a little more defined in
Well,
there.
you have to take it to the least, the person that's gonna interpret it, I guess the greatest, you would say.
You have to take it to whomever is going to interpret this to the greatest leeway, right? So if somebody doesn't understand and they have a double foot in breech, they don't understand that that's not okay. They know maybe that there's feet presenting, but they don't realize that that's an incomplete breech. So you need to be very specific in your definition. And for the record, don't think that breaches should be done at home.
Thanks. So, I mean, I agree, we definitely have to define breach, but I also noticed we don't define VBAC. There's no ambiguity with that, right?
Yes, there's plenty of them.
Oh, so we should define we should define VBAC
To the
too.
extent that you did,
It's not in
I was
definitions.
I was waiting to get there, so.
Okay. No, there's no definition of VBAC in the very first, in 101. So we should have breach just to eliminate any ambiguity or question about what those things mean, since it's part of the expanded scope. And then I don't know that we've spent as much time as we could probably spend. Now that we've got a more mature rule package overall, we can go through some of those definitions and see if we've missed some other definitions. Because if we missed breach and VBAC, it could be, there's probably some other things that we need to define.
I agree, and also there should be on there a definition for trial of labor after cesarean, which is TOLAC. That's what you do to try to get to a VBAC, vaginal birth after cesarean. So that should be in there, TOLAC, trial of labor after cesarean.
We'll look and see if we use that in the rules, we'll define that.
Any other comments on this screen?
say it again. But I was just thinking that July 1st, and maybe I just need to understand more what we want to happen by July 1st, but even if we move it up a little bit more, January 1st, because we want to be meeting. Okay, so I'm just wondering what's happening.
Yeah, I mean, this goes back, this is one of the things that I wanted from the beginning, was to give enough time so that there would be the training time that would be needed, that it would give us the opportunity to work with stakeholder groups and hopefully get more opportunities for the NARM certified midwives to be able to observe and work with VBAC deliveries. And it seemed to me that, you know, you need some number of months in order for that learning curve to happen. And I'm most comfortable with a year. I'm flexible on that a little bit, but it's not something that I'm comfortable with going on. And you didn't suggest July 1st of 2013, and I couldn't go along with that. But we need enough time so that there's enough of a learning curve, so that for the expanded scope deliveries for the NARM certified midwives, that we can be assured that at least that piece has been taken care of. So that's why it's still July 1st. I have some flexibility, so I'm interested to hear what folks think about that.
Well, there's plenty of stakeholders involved here. So there are the consumers, there's the midwives, there's the obstetrician gynecologists, there's pediatricians, there's EMS, there's hospitals, there's a lot of people involved here, and I think it's prudent to give a year's time.
I was curious, where is the language that says what constitutes training by whom? Can you read a book, see a movie, do one? I didn't see that anywhere. I didn't see it in NARM, and I commented on that in writing. The other thing with a prior C-section, the standard of care in the community right now is to be able to do a C-section within 30 minutes from decision to delivery. That's not going to happen in home delivery. You're setting up a different standard that the entire medical community has been held to for probably 30 years. Is that what you want to do?
That's, in reading the rules, it's 35 miles. They have to be 30 or 25 miles. Well, from EMS call to however long it takes to get in the ambulance and get there, and you definitely will be out of the standard practice. So it's a valid concern.
One of the things I'm surprised that I'm the one who has to bring this up, but we removed twins and multiples. Oh, that's this page.
Oh, there was like
Removed.
a presentation.
No, that's this part of the slide, so.
Well, go for it.
Now it's your turn.
Why?
One of the things after the last meeting, we talked a little bit about twins, and I talked to some of my staff in my maternal and child health program that next week, and I asked my maternal and child health folks to pull up and get some data around multiples to help me get a better feel. I've learned a lot about VBACs from the practice bulletins and that from ACOG and others, but I felt uncomfortable with my knowledge of twins, and so I asked my MCH folks to do some research and look into the data around twins. And what I learned is that I started to get more uncomfortable with what I heard, not because of the first twin, but because of the second twin, and the issues that could be involved when, and I'm going to probably say this wrong, but when the first twin comes out, there's like extra space or something happens, and the second baby can move, and it creates issues that could be around the cord, and then sometimes the second one takes a long time to come out. And so looking at the data, it wasn't the first twin, it was the second twin that kind of made me nervous about keeping that in scope of practice. So, so with that, I talked to some folks at the maternal and child health program down at U of A, and talked to some others, and that's when I asked my team to take the twins out for this scope of practice. But it's something I wanted to have a conversation about here at the committee, because that's a new change from our previous drafts. So that was the rationale, was looking at the, because there's no I couldn't find a practice bulletin to inform me as well as I have been informed with evacs. It's really that second twin.
Well, I think when I was looking at it, I saw somebody posted the literature review that you had. And I think I guess I wasn't like convinced one way or the other by it. I felt like it was kind of not very definitive. So I guess that's where I was lacking and not understanding.
Yeah, and one of the differences is, there's actually pretty robust, when you look at the U of A study around the VBACs, the N is pretty big, but twins and triplets and that they're much rarer, and so the database, so there's less data around the home delivery piece regarding the twins. And so with those things in mind, that's when I asked to remove it. But I removed it thinking this is the place to have the discussion. I don't like, because this may be the last draft before the final. So I don't want to just remove it on the last draft before having everyone had an opportunity to talk about it.
I think it's important to appreciate in R9-1601 that you document or you require midwife to provide to clients only low risk. So let me just describe in the training setting for obstetricians for family medicine. Low risk is considered to exclude breech, prior cesarean, and multiple gestation. They are considered higher risk pregnancies. So I would, number one, if we're going to include C-section and breech, to state that. You have by this except, but you really haven't said high risk, nor have you defined low risk. But recognize that, especially in training physicians, we consider those higher risk. It's not something we're going to give to the rotating resident who doesn't specialize in obstetrics, or something that our intern up to probably 6 months into their training of doing at least 50 plus vaginal deliveries, would they be allowed to care for those patients just because they're yet not able to recognize the risk factors involved. Breech delivery, vaginal, they still happen in the hospital, but I tell you who's delivering that in a training setting, that's a senior resident. That's a PGY 3 or 4. So they've been in training for at least 2+ years, more likely 3+ years, and those are the candidates that are allowed to do those deliveries. So I would appreciate that when you put except either one, identify that these are high risk categories, and understand that all three settings, all three of these circumstances are considered high risk by definition in textbooks and in books. I mean, in journal articles and in literature. They are, by a clinical perspective, considered high risk. So you have, in a sort of kind of way, stated that by saying they are able to deliver low risk, except, but identify and be transparent that these are considered high risk.
Well, we aren't doctors, we're midwives, and I believe that there are low-risk breaches just as much as there's high-risk breaches, and they should be defined. I believe there's low-risk twins and there are high-risk twins, and those should also be defined. And I think there is room at home for low-risk twins and low-risk breaches, and I think there is a difference.
I think that the general body of medicine would disagree with you, and that's what I'm speaking to. So as the Arizona Department of Health Services, I speak pretty loud unless you're not able to capture this out there. So as the Department of Health Services, I'm more concerned with that than in your beliefs, quite honestly. I may think that a situation is going to go perfectly well and it's safe for an intern to take care of the patient, but on their first month of being on labor delivery, it's probably not going to have them take care of this patient. And it has to do with experience and understanding the risks and recognizing when problems are occurring. So again, it's a small semantics. Define it for what it is, I would ask. When you say accept, include that as a high risk situation. Why not twins? For everything you stated. It's just more factors, more variables that in a home setting make it a more risky situation.
You know, a majority of time at these meetings, we focus so much on the increased scope. And again, I'd like to state that this was a consumer-driven movement, the increased scope. The midwives, the majority of midwives that are licensed here in Arizona, we just want our rules revised. So I'd like to just kind of, as we have 50 minutes to discuss our draft midwifery rules, is to move forward and we want to define C-section, trial of labor after cesarean, define breach, rape, and let's move forward. That's my mission here is to just, let's get down to the nitty-gritty of how we practice and what we can do to better our goals.
I'd just like to say again, these are rules governing midwives, not OBs. We are not doctors, we are midwives. So we do low risk, and there are low risk breaches, and there are low risk twins that I think are very safe at home. And that's what we need to look at. I also think that we need to look at the World Health Organization and what their standards are for even traditional birth attendants, not even licensed midwives, not even trained, educated midwives, what they're doing in very rural areas, farther than 25 miles from a hospital, and look at their statistics as midwives, not doctors. We are midwives, and these are rules governing midwives. That's where our focus should be made.
So I have a question on page 12. Just to kind of clarify, it's in the informed consent, and also here there's a statement where it says the midwife's notification to the client regarding termination of midwifery services if medical conditions arise or the client refuses intervention. And I wanted to find out, does that clarify, like, if we have somebody that refuses to go in for testing, because like right now we're in a position where at 42 weeks gestation, we don't want to be in a position of abandoning a client, right? Would that be something that would cover that situation? Like if I sit and I establish care with a client and then I realize that after I get her medical records, there's some psychiatric issues that weren't revealed in her medical health history that I don't feel she'd be a good candidate for out-of-hospital delivery, would this then be a situation where if we initiate like a certain medical condition, or if she refuses intervention, that we can then draft a letter, and that would like not consider us abandoning a client? Does that make sense? Because it's in the informed consent too, and I just wanted a little clarification of what that statement means.
You're referring to
Page 12,
G on page
CG, yes.
CG.
And also on the second page of the informed consent for midwifery services, at the very top line, the midwife's termination of service should be should certain medical conditions arise or the client refuses intervention. So I'm trying to understand exactly a little bit more definition of what that means.
I can't find the second thing you said. I see C.
On the second page of the informed consent?
Oh, there.
It pretty much says the same thing in rule.
Okay, so on page 12, C1G, that's just giving notification. You have to provide the client with what type of services you would have to terminate at.
Okay.
So this
you're
is
saying if like 42 weeks gestation, oh, I see.
Yeah, so you would have to let them know, yeah.
Okay.
So this would be like, just to let you know, it's prohibited practice for me to continue caring for you if the following conditions arise, so that they're aware of it before initiating midwifery services.
So if they refuse intervention, like say for example, I've had somebody that I want to transport and they refuse, and I call 911, is that what you mean by that? Client refuses intervention? I'm just trying to
I'm trying to.
Do you follow what I'm saying? Like if I think somebody's in a situation where they need to go to the hospital and they're declining, my initial response is to call 911 and to have the paramedics arrive, and that's kind of where I'm trying to understand is client refuses intervention.
I believe it would be if they refused intervention for anything in 109A is what Tom's telling me. So you would have to let them know that if any of the following came up, that's when you would have to terminate
So
services.
you're focusing on specifically prohibited practice.
Prohibited practice, yes.
Okay.
If you're in the middle of a delivery, I don't know that there's anything, I mean, we
Okay.
certainly don't want you to abandon
Oh,
them,
yeah, I wouldn't.
but,
Yeah.
hold on.
I think that as we get into the nitty gritty, there's no humanly way possible we're gonna get through this tonight. And it really does need some consultation and us agreeing what makes sense and why we're not doing small work groups to kind of get through this. But what's on the agenda isn't gonna meet our needs. So we're doing this in silos. I write in what I think should happen, and I sent that in on a PDF file and had comments, and I'm sure that once the document was available on Word, we all sent in some information. But really, sitting down together and structuring this document would be so much better than what we're doing right now, because honestly, we're gonna get to our breakout groups, and we're just gonna have differences of opinions, and we're gonna go nowhere. I can tell you right away, there's several things that I don't like 36 weeks. Why is that? I mean, term pregnancy is 37 weeks and above, but why do we have 36 weeks? I have another question. You say active herpes, and really, you know, I read some of the comments that were coming through, and it's genital lesions. Well, we all know viral shedding occurs, and you may not see that, so we have nothing in here about suppressive therapy. So, I mean, we're here to do the best by two people. That's the mom and the baby. Okay, and the baby has no comment here, no choice, no, hey, make sure you're providing me the safest environment. And there's no way for that person to communicate that to us. So it's incumbent on us to make sure that we're making the best decisions for that baby. And I just don't think, I think I'd be willing to invest some time in work groups, but I don't think we're gonna get done what we wanna get done tonight.
Well, the reality of it is, you know, these are our rules. This is our practice, and so you know what, licensed midwives are here to stay, and we have practiced, you know, within the realm of safety since we've been here, and we want to continue. But we would like to address some of these issues. And the biggest one that most midwives are concerned about is the removal of all medications in the draft. And it's basically, you know, are we licensed midwives susceptible to felony drug laws if not covered under rules as the rules are written now? And that's a big concern. And I think that, you know, up until this draft, we've been able to administer Pitocin, and now that's just gone. It's just gone. And I think this definitely is something that needs to be discussed, because this is, you know, how we practice. And this is where we look at affecting lives. A shot of Pitocin can save a life. And I need to be able to administer a shot of Pitocin.
So, in order to provide enough structure for this part of the agenda, how many more slides do you have about the changes from last time? And the medication is on one of those, right? Okay, we'll cover the medications at the end, but I just want to have an opportunity to go through the changes between the last draft and this draft, and then we've still got an hour on the agenda to go through on the work groups to talk about the top priorities for each of the membership here. And then, but before we move on to that, we will cover meds. But go ahead and let's press ahead with some of these other changes.
Okay, jumping into the emergency action plan. I made a few changes here based off of some of the comments that we received. There must be a completed emergency action plan on file for every patient. The midwife must attest the delivery place within 25 miles of the nearest hospital with obstetrical services.
Is that for all patients or just EVACs?
All patients.
We really need to address that, because our rural midwives, there is no way. 25 miles in
No,
the
no, no,
hospital?
no, the emergency action plan has to be, but I believe the second bullet point is for the high risk.
The attestation is for
Just for
breach.
VBAC. Okay, I just wanted to clarify that because there was a lot of confusion.
That's what specified conditions.
Yes. And must call labor and delivery nurse at hospital identified in emergency action plan for all patients. When the patient goes into labor and when the patient delivers or requires transport. And this would go into effect with the other rules, most of the rules, July 1st.
Are we spelling out, I have now a question. So the 25 miles is for the high-risk pregnancy?
The
or
specified
high-risk
conditions, those two, correct.
Okay, but is the third bullet point for all patients?
Yes.
Yes.
Okay,
That's why
maybe
it's up
just
here.
specify if it's, and I'll be honest, it's been a minute since I read this, but, I would just be pretty clear to specify which is which, so that it's not confusing.
Any other comments on that? Scope of practice for VBAC and breach. Determine progress of labor for Friedman's curve. Rules allow for change to future standards as established by ACOG. I believe that is on page 16, up top, little c.
So we tried to do some research on what the established standards are for ACOG, and we found one bulletin, and that bulletin talked about a pressure monitor, an intrauterine pressure monitor, and strips, and when to administer Pitocin for augmentation. We do not do any of that as midwives. So if that's the standard, that is not an acceptable alternative. I would love to know the standard
You
then.
identified that you understood what a Friedman's curve is, but if that isn't appropriate, we should spell that out so that it's appropriate, and that it's a centimeter for dilation and descent, and maybe just spell it out.
I understand Friedman's curve,
Okay.
it's the alternative of whatever ACOG standard is.
That's our standard as well.
And that's,
And it's not an alternative.
we put it as an or statement to allow for you to continue doing the progress of labor as you're currently doing it.
So I'm responsible for putting this in. What I was trying to get to is that we need a standard for when to call it in the emergency action plan for when you're doing a VBAC. But I didn't want to lock it into a single, like this is all there is in the published literature in 2013, right? And so I wanted to be able to have, if somebody publishes, maybe we will collect better data here and be able to publish something that in 2017 ends up making it into an ACOG bulletin, and then we're not locked into something that's old. So the purpose behind that bullet, and I don't know if the rule, my intent for the rule for this one is to say, at a future date, I don't want to lock us into something that becomes no longer the standard of practice. But for today,
You mean like breach that wasn't changed?
Like Friedman's curve is no longer used.
No, I'm saying in 1994, this document allowed breaches. In 2001, the standard of care changed and they didn't remove it from the document, is what I'm saying. So I appreciate that you recognize that it could change. And there's been a lot of studies on younger women and older women don't actually follow the Friedman's curve or the standard. So that's appreciated, and I understand what you're trying to do, but understand too why our confusion about breaches being in this document.
Unfortunately, I want to get back to one other thing on the previous slide. The thing about calling the labor and delivery nurses effective July 1st in about 6 weeks from now, this is something new that most hospitals haven't dealt with, is having midwives calling labor and delivery nurses. You know, you've got 40 some odd hospitals are going to have to develop policies and stuff, and they don't even know about it. I know on July 1st, you have to get some fraud. This is not going to work on that time frame.
So what are you suggesting?
Well, you know, a year, you know, you've got to give the hospitals a chance to digest this and understand it, and understand the liability, and you know it's going to have to go through all the attorneys in the hospital and stuff. You have people calling from the outside saying, hey, heads up, there's an emergency that may be happening. You know, how is the nurse and what is her responsibility to the physician? I mean, there's a whole infrastructure here that's not gonna be in place by July 1st or 13th.
But I mean, we could be as collaborative as putting out a general notice to everybody and those hospitals that develop policies and get it implemented before 2014, salute them, celebrate them. But I agree to say we're gonna have them have to be ready by July 1st, 2013 is probably not realistic. And the ramifications, does that mean we're violating rules by not, the hospital's gonna ask that question, are we violating rules by not being ready?
And I think the perinatal trust can help you there because we deal with almost every hospital in the state that does elective deliveries. And I don't know that it would take a year, but there's gotta be some time to get this infrastructure in place.
And once again, I have a question. Are we talking about the home birth midwives are gonna call the labor and delivery departments closest to where they are for normal, low-risk babies? All of them?
Yep.
We're starting labor, and we just had a nice baby. Good night, thank you. Okay.
I'd like to kind of go back to that comment that we were just discussing prior to that change, which I think is a good change, July 1st, 2014. The progress of labor according to standards established by the American Congress of Obstetrics and Gynecology. Maybe if you're looking at the future, we could add to it pertaining to out-of-hospital delivery. Just something that's more geared towards out-of-hospital delivery than normal ACOG.
I don't know that they're gonna change their stance, they're very.
But I'm talking specifically about like the progression of labor. I mean, there's gonna be some standards that are gonna be more for hospital-based deliveries, like with Pitocin or things like that.
I don't know that when we will be there, I hope we are, someday there'll be some body that says, you know, there's a difference and this is occurring. Again, I think there's a lot of, it's bound to happen with healthcare and the extension of collaboration, extension of mid-level providers, etc. But I don't know when and to put it in there, I don't know exactly how you can state that.
But again, in our research, the only bulletin we found was using strips and an interuterine monitor that we don't use, and Pitocin augmentation when it goes off. So
Natural.
pertaining towards natural. Great, instead of augmentation.
Yeah,
Fantastic.
or just, I mean, something more towards just out-of-hospital delivery, which is
A natural birth.
Okay, but, yeah, so we'll keep it.
You can say
content-
excluding internal monitoring. So the point being made is that we don't use internal monitors at home. You know, we use Pitocin, so all we have to monitor here is the fact that the service is changing or not. And so that isn't gonna change, except as you pointed out, that everyone is looking at the age dichotomy and perhaps maybe at some point we'll say, well, if they're 18 or if they're over 35, maybe they're not gonna dilate like we think they are, and we're gonna give them a little bit longer. Right now, that's not in the picture. So I think that's, I think that's relevant.
We get, Karen and I, and we get it, so we'll we have that.
Okay. Progress for the VBACs and breaches must be tracked and reported on the report. As of the draft in front of you, we left out breach, so going towards the slide now, we'll say that little typo there. If the patient does not meet progress criteria, must initiate a transport. And then the Friedman's curve does not apply to the low-risk deliveries, which is the current rule.
So,
Well, the Friedman's curve is what you documented as far as the change 1 centimeter by.
And that's for VBACs and breach only.
so if I'm a VBAC mom, I have to get a vaginal exam every, whatever it is, hour and a half.
So I have a question, if that's not pertaining to all deliveries, when do you decide that this is not gonna happen or progress? At what point? I mean, is it, if it's not by what we've defined by, which I'm very happy is there, by the way, thank you. If it's not that, how does a midwife, what helps them to define that this is not gonna happen, that the passenger is too big for the passage?
It's usually a mutual decision, and if there's been very slow progress, and she's tired, she's exhausted, and usually it's not an emergent situation. She's just been laboring a long time. She hasn't progressed. She's tired. She wants an withdrawal to go to the hospital. And that's an individual woman by woman scenario.
And I think the way that we put this on, it becomes a prohibited practice for VBACs and breach. So it requires transport as soon as they fall off the curve. For the other ones, if they're not progressing, it becomes a required consultation, so they would have to call someone to get a consultation in order to continue someone with an abnormal progress of labor.
Is that stated?
Yes, it's page 20, R9, and that's current rule. And you'll see it's R9 1610 A17. No, that's okay. The rules are, I'm not good with rules, so they're kind of hard to read.
And so at that point, they would just contact whoever.
So if a client didn't want to have a vaginal exam, which is the only way to make sure that they're dilating, they then have to transfer, is that right? Because then they can't report it. Just wondering how that works.
I think that would have to be something that would be discussed under the limitations of, or when it would be required. If this was a VBAC, that would be a specific informed consent with a specific, with required for termination of services. So that would be discussed early on.
And just from my viewpoint as a licensed midwife, I don't do VBACs. I haven't attended VBACs, and I really have no desire to attend VBACs. But if I were in that situation, I would check her, and it may not be every hour, but you're looking at if you check her and then you check her 4 hours later and there's been no progress, you're looking at 4 hours and no dilation, or no change in dilation, you see? So it wouldn't necessarily mean she has to be checked every hour.
As long as that's the case,
I'm just saying, I don't
know how
mean,
it
because
really is technically how it's supposed to be. It definitely has to be checked, or if you just sum it all up.
That's for VBACs and breach, not all.
Yeah.
All right, on page 17, prohibited practice, we tried to provide some clarifications. The first one being on A1, which surgeries were prohibited, incision of the uterus, except as allowed for VBACs, the previous uterine surgery that enters the myometrium. I think before it just said a previous uterine surgery period. And then on page 18, numbers 12 and 13, try to provide a little more clarification for severe psychiatric illness and drug use. Any comments on those?
Oh, I have a comment on something else on there. Is that okay if I bring it up? Item 8 on page 18, you have prohibited practice for a blood pressure of 140/90 with an increase of 30 millimeters of mercury systolic or 15 diastolic increase. And I would like to see that moved to require consult, because if you go to page 20 and require consult, you see item 8, you have severe persistent headaches with visual disturbances, abdominal pains with swelling of face and hands. And those are all, pregnancy-induced hypertension, preeclamptic symptoms, which I think should be moved to require consult.
I completely disagree. First, we're talking about preeclampsia, and preeclampsia comes in two forms, mild and severe. The other that she said, persistent headache, visual changes, that is focal symptoms, neurologic focal symptoms that define the patient as severe preeclamptic. You can be a mild preeclamptic with only blood pressures elevated, and that should require a consult, both of which need, but if you have severe preeclampsia, that is a very high risk situation. It isn't high risk, it's very high risk and has no business being at home.
Absolutely. We agree. I'm not saying I disagree with that, but I would like to look at these in each individual symptom and be able to, differentiate. If she's having, persistent headache, I want to explore that and look at also probably draw some labs and do urine check and all those different things to determine where we're at. But I would like to be able to consult first, because of course, if she moves into severe, I want her in the hospital. waiting for delivered. But I would like to be able to consult first and not be prohibited
Again,
and have to transfer
mild
care.
preeclampsia is high risk. So we're trying to, now you're going from midwifery to practicing clinical obstetrics, and that's not, that has already been prohibited, it's prohibited, and that should not be changed. I disagree.
I have a drug question, unless there's anything else about
Yeah,
pregnancy.
so let's do drugs.
Let's do drugs. So the new drug, the new way it's written in the drug thing, a suspicion of habitual use during this pregnancy, or, keyword, or in the 6 months prior to pregnancy. So 6 months prior to pregnancy, they're having drinks. I have to suspect something, and then I have to rule them out. I find the 6 months before pregnancy a little interesting.
And it's, yeah.
Yeah, it's suspicion of habitual use during pregnancy, but that's not, we need to define that. Because what does that actually mean? Is it, you know, yeah,
I
that.
have a glass of wine every night.
Right.
You're not pregnant? Absolutely.
Yeah, no, we need to get with behavioral health and see how we can define that, because what we're looking for really is substance abuse. It doesn't say that. Okay, that's, I'll take.
Echoing what Lynn said earlier, I think after July 1st, there's going to be a subcommittee or a committee, and I think that this is where some of the stuff needs to, because we're not going to get through this tonight, but severe psychiatric illness, that's an ill-defined term. I think we need to give all of us better help with that one. SMI is a very specific diagnosis. Is that what we're talking about, or are we talking about lesser than SMI? Drug use, again, we need to, does that include alcohol, and does it include what does not? But that's not what we should be doing tonight, I think. This is stuff for the committee after July 1st.
Right,
But we do need to make sure that our rules will be able to accommodate. We'll have some better boundaries around, like you're talking about SMI, around a better definition of substance abuse, so that we've got a hook, and not just an amorphous statement in the rules on that. Those are important ones.
this isn't the final thing.
No. Right.
For everyone.
Right. So let's move on then to medication. Said it right. So I know that this has been a topic that's been a lot of interest from our licensed midwives, and I asked my team, and I haven't gotten anything back yet, or maybe it's in my inbox, which is full, but I've asked for an analysis of what our statutory authority actually is around authorizing midwives to administer and prescribe and that kind of stuff. My general understanding, and I haven't looked at the statutes, is that we don't have the statutory authority to offer that kind of, we don't have the statutory authority to authorize that. So what the rules now reflect is that it's silent on all those matters. But we can't do something if we don't have statutory. I'm receptive if whatever we do have statutory authority for. I'm receptive to including, you know, some elements of that. But if we don't have statutory authority, then we would need that authority before we could put it into the rule. And I haven't seen the analysis yet, because this is, you know, I asked for that about 10 days ago.
So in our statute, as midwives, what give us the right to be midwives, it says the powers and duties of the director, which I assume is you, the director of health services, who we answer to, who's our regulating body. It says adopt standards with respect to the practice of midwifery designed to safeguard the health and safety of mothers and children. It's a pretty blanket statement that that is your first priority, and you'll adopt rules and regulations that ensure the safety of mother and child. So it says it pretty clearly in the law to me that you have authority to make rules that will safeguard mother and child. I understand there's other laws that exist. I understand that this is a humongous problem. I understand that. But as written, the rules right now, just by taking them out, which you didn't take all of them out, which I'm really questioning why you didn't take all of them out, there is a written assumption that you're requiring us to still do this. We just can't do it legally. There's a written assumption that if an Rh negative mom is there, we'll document that she got drugs. She just happened to have Rogam in her medicine cabinet. There's assumption all throughout here that we have these medications, that we're administering them without saying it. And that assumption has to be taken out, that it's assuming that we're giving these. There's one law in particular that points to erythromycin in the newborn that does specifically say that midwives need to do this to newborns, and yet we can't obtain it, we can't possess it, and we can't administer it, even though by law we're required to do so, because we can't do it anymore. This is a humongous problem, that there's so many assumptions in here that we're going to do it, and we have to record it, but we can't do it, especially the life-saving ones. It's just not acceptable. I mean, something has to happen.
And I brought this up, and I had emailed a while back about, I had called the Arizona State Florida Pharmacy, and I spoke with Deputy Director Cheryl Frush. And she seemed to rattle off things, and she is more than welcome to come, be on the agenda, and present on how we could word things. An example she gave me was an optometrist. There actually is a list of drugs in the rules that they can possess. So they list the drugs that they can possess in the optometry rules. So she used that as an example. So I think we have that to maybe contact her, and maybe she can help us with that. But I definitely think it's something that we need to work on. And if we do have to pursue statute to really truly fix this, because Director Humble, I appreciate you and what you're doing for us so much. It's really great that we have you and how you're here and you're meeting with us. But we need you to commit to us that if we really need to fix this and we need to open statute, then we need the Department of Health behind us to do it. Just because we have so much opposition all the time and we can't do it alone. And we would really like to fix it and have an amazing rule rewrite here in this state and be an example for the world. Because the department does have a huge health and safety liability issue by taking out life-saving medication that is in the moment. Pitocin alone. I mean, we were asking for Cytotec as well because that's the standard of care, but minimally Pitocin, a life-saving drug that has to be in the moment. I mean, that is a health and safety aspect to mothers and children right now. And to take that out and make it in effect July 1st is a humongous liability for the Department of Health. Huge, if you are a regulating body.
I think you have bigger liabilities by adding previous cesarean section and breach. Quite honestly. That being said, if it isn't in your realm to be able to change those rules, then we need to have some kind of safety net, fix, backup, whatever we're going to call it, and that's collaboration. You're going to need to have somebody that can provide you with those medications, and that's going to require your infant to be to the pediatrician as soon as possible. It's going to require the collaboration of a physician that can get you those medications. And I'm sorry, we have to abide by rules that we don't like either. But it is what it is, and maybe those statutes need to be altered. But really, I don't think pointing out the liability, and I would have assumed Director Humber was quite sure of the liability risks that he's taking all the way around.
So you're alluding to standing orders, that a collaboration of a physician that would write us standing orders, and absolutely, if there are physicians that are willing to do that, but there are not physicians willing to do that. If you're willing to do that, happy, 40 midwives will be at your door and you can write us all prescriptions of standing orders.
So I'll just say one last time, you know, we have a few weeks before this is final. I know this is an issue. I want to make sure what our statutory authority is. I want to look in and see, I know the broad 36 authority. I need to know what the other statutes are.
Sadly, there's a lot of medications we wish were over the counter and available to you, okay? We wish birth control pills were over the counter and available. And I know ACOG is fighting for that to occur one day. And maybe someday Pitocin will be in some fashion with you can demonstrate that you have a license that is available essentially over the counter. But I think we're dealing with other rules that we have no control over right here, right now.
But what I'll commit to is looking to see, my interest is in having this to be a better system. And I appreciate what you said at the beginning today about how everyone keeps talking about the scope of practice. I've been looking from the very beginning about this as a system. And my goal is to have a safer system in the end. And folks that look, if you just look at one piece, like scope of practice for those kinds of VBACs that we may allow in the end, it's not fair to say that the system is worse. People might disagree with whether VBACs are added in the end under certain circumstances, but the system is what I'm interested in making sure is better. The NARM certification, the clearer standards around, the initial certification, the advisory board committee, the better data collection, there's a whole host of things that are in these rules. I know some people don't like calling the charge nurse. I like that piece because it builds and hardwires communication over time. So, I think there's a lot of things in these rules that build a better system. And so that's my interest. And if a better system includes having it safer to deliver low-risk pregnancies in the home because of there's certain subset of medications, I'm willing to look at that. If we don't have the ability to do that in this rule, I'm receptive to moving forward, not for everything, but for the gotta haves that make real sense to make, the low risk pregnancies and these others, so we have a better system. So I'm willing to look at that and moving on. But what I can't do is violate other parts of state law that I won't do. I can. But then, like with medical marijuana, I'll get taken to court and we'll have to change our rules. So, so with that, is that your last slide?
One more.
Okay, we have one more slide, and I want to make sure that we have enough time to do the presentation and the breakout sessions.
Can I just say though, if you are taking out all our medications, you need to take out the assumption that we're going to get them, which is in there all over the place. It has to be taken out completely.
We've already looked into that. Last slide, advisory committee. There's been no change since the last set of rules. The committee's really established to review the data from the reports the midwife submits, examine the evidence-based research, recommend to the director changes in the rules. And it still consists of 2 licensed midwives, 2 consumers, 1 licensed physician, and 1 nurse midwife, and that would go into effect right away.
It says under the for the consumer, she has to either given birth or have good understanding of home birth. And I think that should be also for the physician and the CNM, because there could be so many OBs out there and so many CNMs who just have no understanding at all of home birth, and I think that's just not productive.
I think you need to define licensed physician a little more narrowly. That could be anybody. It could be a dermatologist. It is, okay, so it's MDDO, practicing obstetrics.
It has to be midwife dominated. It is a committee about home birth and about midwives, and it has to be majority midwives. And I think consumers might stand behind me to say only 1 consumer needs to be on there to be given to another midwife. A midwife must be the majority, must.
Yes.
Okay. So what if we went 3 licensed midwives and a consumer? Okay, we'll change it to that. All right, done. Okay, so the next part of the agenda is to talk about recommendations. And so let me tell you what I'm looking for here is we've got some pads of paper here, and folks on the committee can get together. I don't want to direct this. I want you to develop your own organic groups that you decide who you want to work with, and come up with your gotta haves and your can't live withs. That'll help us do that next iteration of rules. So if you can sort of boil, I know there's folks that have lots of different concerns, but if you put your concerns into your A list and your B list and your C list, what I'm interested in us talking about next is the A list items, the gotta haves, I love this stuff, and the I can't live with this elements. And that's what we'll capture on these pads, and then we're going to take that back for the next iteration of the rules. The first part, we have 50 minutes, so we're just right on time. If we have 10 minutes of this breakout group, and we'll try to stay true to that, we'll have 30 minutes for everyone to make the presentations, assuming we have 3 groups, and that'll be 10 minutes each. And then we'll have a general discussion that's more open-ended for about 15 minutes. So that's what we're looking for next. And so I'm talking about the committee, not the audience people. So, and on the internet you can tweet. Okay, so who's organizing this next part? Is it me? Okay. I didn't delegate this, so this is what I get. Okay, so like I said, I'm not going to prescribe the groups if the physicians want to work together. And
I'd actually like to work with bipolar opposite.
Okay, that's why I don't want to direct this. There's 3 pads of paper. There's the folks on the committee. Nobody's on the phone today, so we don't have that issue. So just work within your groups, decide who you want to work with, come up with your gotta haves, and you can't live with the following. So we'll come back in 20 hours.
Yes.
Go ahead and get started with the presentations. So do we have any volunteers to go first? Go right. You get some Tesla. Okay.
I think maybe we just kind of focus on the gotta haves, and that's kind of included what we don't want. For me, as a consumer, one of the big things is just autonomy. And some of the other states, specifically California, and I brought what they have in their rules, is they have in there so that what they call is the client's right to self-determination. And it gives us as a client the right to refuse some things. And maybe I'm not reading the rules correctly because I find something new every time I read them, but it looks like some things you can, like chlamydia, you can refuse testing for that. But could I refuse testing for gestational diabetes? Or could I, refuse testing for, I don't know, any number of things. And maybe it's in the quarterlies, and I don't pay much attention to the quarterlies, maybe that's why I'm not seeing it, that it gives the ability for the client to refuse. But I want to be able to see that I have the option to refuse some testing and treatment, and that my midwife won't be liable, because it could be a written refusal. And I get that. I wouldn't want it, I'm not saying that, every single thing, like all of the, everything of their prohibited practice. I'm not saying I want to be able to opt out of that and they still have to serve me. I get that and we have to figure out a way to write it. But, so that was a big thing for me, is that I have autonomy as a consumer, and that I'm able to make choices. And I'm just the same as if I was seeing an OB in a hospital, I wouldn't, I'm able to make choices because I'm able to do that.
So is your ask for that the midwife is not held liable to you refusing?
Is your ask that the midwife is not liable for your refusal, and so thus she doesn't have to discontinue care? She still has to document that you refused, correct?
Yeah, or if the client refuses to do a diabetes test, that would be a mandatory.
And is that currently, that's what it states in the rules? That
Well,
it's a mandatory disconnect?
We need some clarification.
Okay.
one of the other things that Alice and I agreed on, that so much of the conversation the last 6 months has gone on because we don't have good data. And there's been no accountability to the midwifery community of providing that data. So going forward, we want to see good data, good accountability, so we can start making some decisions based on data. And the other thing that we agreed on was that whatever happens after July 1st needs to happen. This can't die. We can't just say, okay, we came up with this set of rules and now we're done. There's so much more that has to be done, and we're both concerned that this dialogue is going to stop. So I think that the department needs to make sure, from both of our standpoints, that the dialogue continues and a lot of these things get ironed out.
Well, this one's kind of a big thing for you too, but just define a midwife's capabilities of being able to attend VBAC and breach, right? That was an important part.
You know, I was thinking about that one, and I would really love, as we finish, and I don't know if this is our last meeting, but to really go ahead and set that midwifery advisory council meeting, you know, to have that in place where that council, whoever they may be, can start on it.
In the implementation, I mean, just an idea, in the implementation, it's probably relevant to keep everybody that was on this committee until we have full implementation, and then select a committee that's going to stay with it or have rotating. But I mean, a lot of us invested time and energy into this, and for somebody altogether new to be involved during the implementation process is probably not wise.
So basically, we just said to just keep the process going and make sure we understand what are we doing. And, you know, if some of these things aren't being implemented until next July, what's really going to be happening so that we're not sitting around and just enforcing the dialogue, making sure that happens. And I want to make sure that we keep looking at this medication stuff so that something gets done. And a big thing for me is for the VBAC stuff. Maybe we need to look at and redefine the terms for failure to progress, CPD, because there isn't a good definition of that. We talked about it last time. It's overdiagnosed, and you know, maybe somehow we can figure out, well, what about these moms who were induced? They weren't even in labor at all. They had no signs that this baby was coming that day, and they ended up with C-section because it was failure to progress. But that's a total different ballgame than somebody who actually started labor and looked like, you know, their body was ready to have.
But it states failure to dilate. That's where my confusion lies. It states failure to dilate. So, I mean, that definition, I mean, most people dilate. Unless they have a breach and they have a C-section or a breach.
So.
Yeah, we got to fix that.
Yeah, that's not.
Yeah, it says failure to dilate.
It used to say both, and now it just says that.
You took the wrong one.
Okay.
I'm sorry, it should be progressed.
And I didn't put it on there, but another big thing is just that if we do keep, you know, whatever the committee makeup is, however we do it, I really, really think it's really important to put the same exact clause that you have for the consumer, that you have to have had a baby at home or have a good, strong interest in midwifery care, because that is, I think, it's really important. Because an OBGYN should know stuff as an OBGYN and then also understand home.
I somewhat disagree, and I would request from a physician standpoint that it be an obstetrician gynecologist with good quality experience and background, because they're going to be your consultants, quite honestly. And they better know obstetrics and gynecology. You're going to be the experts in home deliveries, but they're going to be the experts in obstetrics.
But that's what I'm saying. So,
so it doesn't matter that we've ever been at home.
Oh,
I
I
can
think
still.
it does.
I understand that you think that, but my purview is not going to necessarily, or my opinion isn't going to be based on considering the home environment. I'm going to give you an opinion based on the standard of care that is presented by the American Congress of Obstetricians. It doesn't matter. It's a standard of care of obstetrics. So I think you really want somebody who understands the guidelines.
Shouldn't an OB with home birth, like a knowledge of
I don't know the answer to that question. There are unfortunately some of my colleagues that probably aren't as up to date as they should be. And I think it's relevant that we have somebody of the best quality.
But one thing I do think we need to do, and when you look at the rules, it just says a consumer, but it doesn't say, like with the others, it's got some qualifying In other words, needs to be somebody, has to be somebody interested in home birth. I don't think it says that yet.
It does say something.
Does it for the consumer?
Uh-huh, that's what I think we should use the same exact.
It's on the very last page.
Oh, experience with midwifery. Okay, all right, so that's covered. Okay, so let's.
And just to say, the committee, I guess, is going to be collaborative committee, not antagonistic. So therefore, having physicians that are a little bit more willing to work with us, I think is a great idea. So, we have a couple gotta haves. We also just did gotta haves, not the other. Sorry. Number one thing, I realize we're in a conundrum, but meds has to be addressed. These were the fundamental drugs that we came up with, but it has to be addressed. Life-saving meds has to be there. Mother's autonomy, which I think Allison so clearly defined, and I don't want to go into because it is the mother's choice, and that right to refuse. I personally believe anything, as long as they're educated on what it is, they have the right to refuse anything. My biggest point is emergency measures. The whole thing is a little crazy, but I'll just point out a few of the major ones. The first one is, before we can do anything emergent, we have to call 911. So a head comes out and it's a suspected shoulder dystocia, but I have to go call EMS before I can do that shoulder dystocia. So that is the clarifying term above all of the emergency measures we're allowed to do. That is not okay. I do not want to stop in the middle of an emergency to call EMS. I need to handle the emergency and then call EMS. I have no problem calling EMS. I just want to do it the
Or
appropriate time.
instructing someone else.
Or instructing someone else. Absolutely. But sometimes I'm alone at a birth, even if I don't want to be. Sometimes I arrive. So that's the biggest thing. And then within the emergency measures, there's a lot of limiting things that I think need to be addressed. The first one on the list was episiotomies. We are only allowed to do a midline, which I believe there are a lot, and that is usually not one that's done frequently. So we need a little bit more leeway on the kind of episiotomy, not just a midline. There is only one way we can dissolve a shoulder dystocia, and that's to rotate the shoulders. There are many maneuvers, and we need to be allowed to use all of the maneuvers to handle a shoulder dystocia. Right now it says we only have one way to do a shoulder dystocia. It also reads that we can manually explore the uterus. That does nothing to stop bleeding. I need to manually remove the placenta if there is bleeding. It does not give me permission to do that. It only permits me to explore. That has to be expanded. The other thing is all about suturing. A woman tears. Right now it's under emergency measures, and that's the only place in our rules that suturing is talked about. It's most of the time not an emergency measure. Sometimes it is, which it was defined as suturing to control bleeding. Agreed, I will suture to control bleeding, not after I call 911. But I need to be able to repair simple repairs without it being an emergency and be able to do it safely at home. So that was one thing we wanted to do. The last thing I'll address is the consultation. Within the consultation right now, it says a written consultation. I think we should be able to do oral and written. I want to be able to call a doctor, to call a nurse midwife, and consult over the phone without something written right then and there. So I think it should be an either or, written or oral. And CNN should be able to consult with us.
So I have a question right now. Do you, as a CNM, do you have to consult with a physician if you're doing deliveries at home?
No,
Okay.
completely autonomous.
So that's obviously.
Yeah,
somewhat
certified
like-
nurse midwife doing home birth or birth center birth is completely autonomous from physicians.
And so there's no supervision.
Zero.
That seems like the most logical approach, honestly. To include that in the language.
Oral.
And oral and written.
No, to include a CNM in the language.
Oh, yes.
Love to consult with you.
Yes,
Right.
that would be amazing.
So, Mary and I don't disagree as much as you might think. So these are Mary's gotta haves, and that's open statute to allow for emergency meds, or meds that are basically stating that they need to be delivered, but they have to obtain these meds from some other mechanism other than here, or simple mechanism. So open statute or push for open statute so that they can have medication to prevent postpartum hemorrhage, that they can provide erythromycin, vitamin K, RhoGAM as the patient needs it, and oxygen in emergencies. And we want to ensure, but also assure EMS. So, albeit Wendy, I understand what you're stating. All of us have been in emergency situations, and the first thing we do is call for help, and that needs to be done. So hopefully you're not alone in deliveries very often, and somebody else can do it for you. Unfortunately, the way it's written, it sounds like the nurse midwife has to do
We're
it.
gonna change that to ensure that
Ensuring,
But but I would just state as precautionary, if you are alone, you still need to get somebody coming to your rescue, because shoulder dystocia, and I would do that first before I did anything else. So have that cell phone on your hip. Furthermore, we looked at changing it to perform episiotomy. Most of us don't want to perform episiotomies in the hospital or at home, but when they need to happen, they need to happen, and putting the limitation. I think it's important that the patients understand what your experience is, and how many episiotomies you've done, and how many breech deliveries you've done, and so I think in full disclosure that should be included. And I agree that tears should be repaired to the best of your capability. Obviously, I don't think you should have to wait for the patient to be hemorrhaging to repair tears and or episiotomy. And I agree as far as manual expiration in attempt to remove the placenta. So those are Mary's gotta-haves. I don't have a problem with them. I know this is an issue, but the way the language is in the rules right now, it implies that they have to make sure these things happen, but there's no mechanism for it to happen. So that needs to be investigated. And then we go to my asks, which are remove prior cesarean section, breech, and multiples. And the other is, my must-have is if we do go down this route, or regardless, I just really think we need reporting transparency. So I would recommend that we have a total number of planned births, including number of planned home births with fetuses in breech position, the outcomes of the pregnancy. So I'm asking that all this data is public, and whether it's in the 3-year aggregate, but so that the public can understand that planned births are happening, and here are the outcomes. So the outcome of the pregnancy, outcome of complications during pregnancy, labor, and delivery, number of planned home births for clients with previous cesarean sections if we do go that route, and again, I'm not in favor of it. Outcome of pregnancy, any complications during pregnancy, labor, or delivery, number of patients requiring transfer, condition, and circumstances arising during pregnancy and delivery that require transfer of care, and reported complications during pregnancy, labor, and delivery. I just think it's just, the transparency needs to be there. We have the transparency. We need to know what we're doing in our outcomes. So those are my asks, my request, and Mary. So I'm not that far apart.
That's a good one. And so one of the things that one of the advantages we have with being on live stream is we have the notes from each of the cards, but we also have the full presentation. So what we'll be doing, our team will be doing, is to go through, because some of you were going so fast I was trying to catch up myself, but we've got it all on tape, which is a nice thing, thanks to our team. And we got the papers, but we have the color commentary, more importantly, that goes with it, so that we understand the nuances there. One of the things we can do is, in terms of reporting transparency, the committee isn't on the hook for anything yet. I mean, they have to meet, and they shall advise the director, but one of the things we could do is hardwire an annual report to come out of that committee that provides, that goes into the details of what, summarizes. Right, it'd be like the child fatality review report that we do with Mary Rims on that, where we've got an annual report that comes out that now we've got it deliverable for the committee, and I think that's, for the advisory committee, I think that's a good idea.
And I think to Alice's point about autonomy, I would hope that everybody understands that patients have autonomy and have the right to refuse any care, whether it's in the home or in the hospital setting. So when my patients refuse what I suggest, that doesn't mean I abandon them. And so if anything in this document implies that a midwife should have to abandon her patient, that's wrong. But like you stated earlier in the meeting, they should have, the patient should have an understanding. If you are going to be essentially what we call non-compliant, I have the right to not be your midwife any longer. And so that should be in there and protected for the midwife. She shouldn't be forced to take care of somebody who won't take her
It
recommendations.
should be within, in other words, it wouldn't be a deficient practice to stop providing service, but it would be deficient to abandon. So we have to,
There's sometimes situations. So
They know in advance that document that you had recommended. So they know if I suggest that you get a diabetic screening and you refuse that, I'm going to be uncomfortable because I'm putting myself at risk for shoulder dystocia. I'm putting myself at risk for the baby having bad outcome immediately after delivery, and I personally don't want that risk. So you have to understand that I respect your autonomy. You're going to need to find another midwife or another practitioner.
and that would be happening earlier in the pregnancy, so there'd be times that wouldn't be abandonment, like it would be something happening during the delivery that she doesn't want to have happen, and you can't abandon it. That's abandonment. Versus earlier in the pregnancy, if they don't want to do something that's critical, then the midwife would say, we had an agreement going into this, and I'm not comfortable continuing, and we have to make sure that's not a deficient practice for that.
And one of the other things that we're trying to do is we're trying to walk the fine line. There's some testing that is required that identifies you as a high-risk patient. That's a prohibited practice, and without that testing, you may not be able to identify that. So we want to make sure that that testing gets done, like HIV, syphilis, those types of things, because those are higher risk then and become prohibited practices. So if there are, and diabetics. So that's why some of them, we did require them. If there's some language that can do that, but you still can identify those conditions to prevent those high risk, pregnancies from continuing on, we are completely open to language on that. But that was our point in requiring some of that testing. That's why chlamydia, not a required, but HIV and syphilis and those types of things is required. So there is some reason behind our madness with rules.
Going back to the meds on that presentation, I agree completely. We can't go halfway. It has to be one way or the other. So we'll look into the statutes. If I absolutely do not have that statutory authority to do that, that'll answer that question. And then the elements that provide that expectation will be removed, because it's not fair to have you on the hook for a deficient practice for something that's a class 6 felony for you to do. Right. So,
and it also limits full disclosure and transparency.
right, because there could be an expectation. Right, I totally agree. So, in the next week or so, we'll have a really much clearer view of what it is that we have the authority to do. If we don't have the authority to do any kind of meds, we'll pull that out of the rules. And then my personal commitment to you is that after that, then we can work, the committee will be over, we won't have open meeting law. I can meet with you and we'll talk about next session in terms of, what makes sense to make sure that you're providing safer deliveries in the home for things like oxygen or, erythromycin and that. So any other, same kind of thing on this board, evidence-based emergency. There was something in the middle of that presentation that I thought was really important, and I can't remember what it is now, but it's on camera.
You have a on the shoulder dystocia, perhaps it's very defined in what they can do, but there are many other maneuvers that are
the placenta, moving the placenta out.
I mean, what you probably should say is more what they can't do as far as shoulder dystocia. So maybe you want to say they can't do some episiotomy at home. I mean, other than that, or Zimvanella maneuver. But to only give one maneuver that they can do is probably not appropriate.
That's setting up a less safe thing, because I can't do this even though I know it would help, kind of thing. Okay, so we've captured that on camera, and I think that those are things that we can definitely do. And Kara understood more of that than I did, and so we'll get that into the episiotomy and those things. I think that was a good discussion, and I think those are good things that we can include around that. The autonomy, I wrote some notes on that, and we'll definitely need to make sure that we clarify the difference between abandonment and cessation of services, and make sure that we're not putting folks on the hook for that, but holding them during the delivery, obviously that's different.
Well, that's like at the 42 weeks too.
Yeah.
You know, when they get to 42 weeks.
Which then they
Then
can't do it
I can't
anymore.
do it. So my method is I take them to the hospital. I go with them,
Yeah.
I meet them there, I bring their chart, and they present.
Right.
So that's how I do things as a licensed midwife. If they choose not to go, they absolutely have the right to refuse, but I'll be there. I will be at the hospital with your records at this time. So what they decide to do with that is,
Yeah.
but I follow through as far as
Right.
so that I can make sure that they have care.
Right.
And then, not to beat a dead horse, I just passed around the Oregon data again. And I think it's really important that we recognize that our literature search or review stated a threefold, and the Oregon data states a much higher poor outcome with prior cesarean sections at home. So or planned home deliveries in general, but I'm sure it's because they don't have limits on, well, I know they don't. They can do breaches and prior cesarean sections and any deliveries at home. And I want that to be recognized. I mean, it's not it's not turf issue. I really believe in my heart that these are higher risk deliveries, and that is why I'm asking for them to be removed.
But again, the Oregon study includes unlicensed, unregulated midwives. We want licensure. We are regulated. It has not anything to do with us.
Yeah, and I think going back to the system part of this, I think one of the things that, if we're all sitting in this room and at the end of, or middle of 2015, we're going to have some pretty robust data around all these issues, and we'll have an advisory committee to help, look at that data. We'll include a deliverable with that committee so that we've got something that's a deliverable that'll help us prospectively as we collect this data, because it's electronic, because we're going to have a better system. It's just the system will. I think everyone, no matter whether you agree with the scope of practice or not, that we come out with at the end, I think everyone at the table is going to agree that the system has more checks and balances in it, that the system is more collaborative, and that the system as a whole should be safer, even if we include limited circumstances with some kinds of evacs that meet the screening criteria. And we still have to address the breach issue. I gotta be honest with you, from what I've seen, I don't think that we're gonna add the twins back in the final. So I just wanted to be honest with everybody about that. So we have only a few minutes left. One of the things that we have to decide as a committee is where we're going to go from here. So it's mid-May. We have to publish and file these rules by mid-June. In order for us to make that happen, if there's any changes, in other words, if we're going to have another committee meeting, it needs to be at the beginning of June.
I think the law that we passed, the SB 2247, says that we have to have one last meeting of the final rules. It's pretty clear there.
Oh, so
we have to have one.
We have to.
The final.
Of the final rules.
Well, it says within 30 days after publication of the department's website of those recommendations and publications of the draft of proposed rules, the director shall conduct a public meeting and receive comment on the final draft of the proposed rules.
Proposed.
The final draft.
The final draft of the proposed rules. So what we.
So where's the final draft?
So that's yeah. So okay, good. No. We're gonna have to have it if we do have to have the meeting. Let me check my calendar real quick while you talk, Kara.
You know what? what, I'll just talk real quick, because I want to make a statement. Earlier, I said that I don't personally, as a midwife, want to attend VBACs, but I do support the woman's decision if she wants to have an out-of-hospital VBAC at home. I do support a woman's right to choose whatever she wants.
All right, and one thing while Will is checking his calendar, we certainly can go back to the data issue. I think moving forward, especially with the new rules and the new reporting requirements, I think we are going to get a lot of the data that we want, and we're going to be able to see not only all of those that deliver, but anybody who presents for midwifery care. So I think we're going to get a really good picture. We also will be providing updated reports. Licensing will be hiring an epidemiologist that will be able to analyze this data once we get it. And getting electronically is going to make it very, very easy. And the University of Arizona has also offered to continually work with us on our data as well. So I think moving forward from July 1st, the data that we are going to be able to give back to everybody is going to be much better.
And we're going to publish it. I'm really committed to it. I mean, we could change things here in Arizona, but the way you change the nation and the way you change the world, like we are with cardiac arrest, is by publishing. And that we're changing the way change survival of cardiac arrest around the whole world because we're publishing our stuff. So I'm going to be in DC the whole week, 10th, 11th, 12th, 13th, 14th. It's going to have to, for me, if I'm going to go, I need to have it, and I don't have to go, but I want to, the week of June 3rd. And we could do, we have to have the final, so in order for this to be a meaningful meeting, to meet the statutory requirements, we've got to have the final proposed rules published, that we can have that meeting if I'm going to be there by the 5th. So Tom, can we have the final, we can have the final draft by?
Is it possible to have what looks like the final draft sent out to us in a week's time? Bear with me. And then allow to the committee and allow the committee to send back on Word document any communication. That way, when we come to that meeting the first week in June, it's what we kind of all had at least talked about. It doesn't have to be in there, but once we see the final draft, any comments that we want to add or because it's been forgotten. No, if we all are included in it in that email. So if they
But then it's not
No. When we come to the meeting in the first week of June, it will be done and A-OK, and then it'll be open to public comment.
Seems like we wouldn't be allowed to do that, since we haven't been able to, like.
You know,
We
okay.
have been able to,
So
we just don't.
here's the thing, we're
Not closed, open.
Well, so here's the thing. We've got 19 other rule packages. We're doing assisted living centers, skilled nursing, hospitals, behavioral health facilities, inpatient, outpatient. We've got all these rule packages, and I got like 8 people. So what I'm driving at is we may need to have this, the next meeting be on, say, the week of the 17th of June. You can't do that.
I'm going to be in Peru. Delivery babies at home.
Well,
We're not home.
In the hut.
I'll be back. Okay, so I have a window.
Probably be just diagnosing STDs.
I have. I have a window on the 13th.
It actually has to be published the last week in May, so we will be ready because we have to give the 30-day comment period, and it has to be in by the 28th. So we are tied to that anyway. So we can meet sooner.
Can we do Monday, June 3rd or Thursday, June 6th?
I'm on call June 6th, so I'm in favor of the 3rd.
We can try the 3rd. We would just have to check to make sure this room is available. There are a couple of logistical things we have to check on. I'm also looking at Gannon and Jen. June 3rd. But we can definitely check and get it out tomorrow.
Okay, so the commitment we've made here is to finish here's the thing about the 3rd, is our obligation, we absolutely have to publish the final draft rules by Friday, June 31st. Okay? No, the proposed. May. There is no such thing as June 31st. May 31st is when we have to have the draft rules, that final draft rules done. Now, if we have, let's say we barely meet that threshold, and if we have the meeting on the 3rd, everyone's only had like 2 days to look at it. So later in the week of the 3rd would give people more time. So
I don't think it really matters.
Thursday or Friday the 6th or 7th.
I can do the 6th.
You're on call the 6th.
I'm in the hospital.
How about the 7th?
And I'm on
Friday.
call the next day. I'm in the hospital the next day for 24 hours. So
I think people can read it.
How about the 5th, which is a
We can all
Wednesday?
read it in 2 days.
As long as you bring me a birthday cake.
It's not gonna be, is that your birthday besides?
Still all read
Well, let's
that.
do the 3rd and everyone can, it's not gonna be radically different. I mean, we're tweaking now. So, I mean, they're important things, but in terms of the language that we need to incorporate, we can do that. Okay, so we'll commit to getting it done by the 31st of May, hopefully a couple days before that. And then we'll have the meeting on the 3rd, and it'll be in here, and if somebody else has the room, I have the authority to throw them out.
Dr. Chris, can I ask a question real quick on the quarterly? Because June 30th ends the quarter, so we'll be doing the new quarterlies for July 15th?
They won't any longer be quarterlies. So
So we'll be doing the new system.
the new system starting, yeah. So the new system will be starting on any patients July 1st.
Yes. But the quarter ends at 30th.
Right. So anybody, what we would say is starting July 1st, anybody you terminate services on, whether you've completed their full postpartum course or decided it was somebody that you didn't want to take, then anybody that has that July 1st or after, you would do that.
So any deliveries before July 1st, I would do the normal rules quarterly.
Yes, you would do the normal quarterly to close it out as of June 30th. Okay? June 3rd, 4 to 6, is that what we decided? Okay.
I would like to just ask for public comment to be a part of that. We had it in the first couple and then we took it out. And I think it would be really important to hear from the public. We've all beaten the dead horse a lot and it would be nice to hear from them last time.
Yeah, and I think we have the time for that because the next meeting won't be, it'll be a presentation by the department of what our proposed final rules are. And then that will give, and I think that we can have sort of an open forum at that point. And obviously, folks on the committee can weigh in on what they thought, but I think we made a lot of progress today, maybe more than we have in other meetings, because we're getting down to some of the brass tacks and details. We've captured all that. Okay, well, it's 6:02. Have a nice evening. Everybody buckle up.
Thank you.